Hello, I'm Kripa. I'm going to discuss about the complications while initiation of CPB. CPB is a form of extracorporeal circulation. It temporarily takes over the function of heart and lungs during surgery, circulation of blood, and the oxygen content of the body. To facilitate surgical intervention and provide motionless speed and provide bloodless field, CPB is used. Cardiopulmonary bypass basic system. Blood is drained from the venous system utilizing gravity through cannulas put in the SVC and IVC or a single cannula in the right atrium. Into the then the blood comes from the cannula from the SVC or IVC or right atrium taken to venous reservoir. It is pumped into the membrane oxygenator and returned to the system via a cannula usually placed in a distal ascending aorta. Venous drainage. Venous blood enters the circuit by gravity or siphonage into a reservoir placed 40 to 70 centimeter below the level of heart. The amount of blood drained is determined by CVP, enthalpy change, resistance in cannulas, tubings, and connectors, absence of air within the system, inadequate blood volume, excessive siphon pressure. Venous cannulation techniques include bicaval, single caval, and cavo-atrial. Venous cannulation drainage complications, atrial arrhythmias, atrial or caval tears and bleeding, air embolization, injury or obstruction due to catheter malposition, reversing the atrial and venous lines, unexpected decannulation. Venous catheters may compromise venous return to the right atrium before or after the CPB, entrapment of the intracardiac catheter by a suture, improper post suture placement obstructing the cava when tight. The causes of low venous return include inadequate height, malposition of venous cannulas, obstruction or excess resistance, inadequate venous pressure, King's airlocks, or insertion of PA balloon catheter into the cannula, surgical manipulation, hypovolemia, etc. Sites of atrial cannulation include proximal aorta, innominate artery, distal aortic arch, femoral artery, external iliac, axillary subclavian. The choice is influenced by the planned operation, the distribution of atherosclerotic disease. Ascending aortic cannulation. For that cannulation, two purse strings partially inserted through the aortic wall, mean arterial pressure of 60 to 80 mm Hg, 4 to 5 mm full thickness of stab wound, insert the cannula under a finger, position the cannula to direct the flow to the mid-transverse aorta. Proper placement is confirmed by noting the pulsatile pressure in the aortic line monitor and equivalent pressure in the radial artery. Advantage of placing cannula in the ascending aorta, it is because it is safe and no additional incision is needed. If pressure is too high, greater chance of tear and dissection. Pressure too low, aorta tends to collapse, difficult to make incision and a greater risk of tear. The potential complications like atherosclerosis with or without calcification. Atherosclerosis is the risk factor for perioperative and aortic dissection and post-op renal dysfunction, intramural placement, air embolism from the cannula, persistent bleeding around the cannula, malposition of the tip, aortic dissection and high CPV line pressure. Complications like difficult insertion, bleeding, tear in the aortic wall, malposition of the cannula tip, atheromatous emboli, failure to remove all air from the arterial line, injury to aortic back wall, and aortic dissection. That's about the complications while initiating cardiac surgery.